We're going to get started here. Hey, welcome to the Davies Use Case webinar being presented by Lafayette General on PSI-15. This is a Davies Award-winning use case for the value of health IT. My name is Manager of Quality and Patient Safety, and it's my pleasure to moderate this presentation. Promoting the use of health IT to improve the quality of healthcare delivery. HIMSS integration of clinical decision support and best practice guidance. Access to clinical data to analyze progress, and IT-enabled patient safety tools for all healthcare organizations, clinicians, patients, and community members as vehicles for improving patient outcomes. The HIMSS Nicholas E. Davies Award of Excellence is the pinnacle of the HIMSS Value Recognition Program. The Davies Award recognizes outstanding achievement of organizations from around the world who have utilized health information technology to improve patient outcomes and value. Davies Award-winning use cases have been peer-reviewed to validate sustainable, improved patient and business outcome resulting from health IT-enabled care delivery. It is my pleasure to welcome our two speakers for today's call, Rachel Brunt and Jesse Hanks. And Rachel and Jesse, thank you for joining us, and I'm going to turn the presentation over to you.
Good morning. My name is Rachel Brunt. I'm the Director of Quality for Lafayette General Medical Center. My background is nursing. I've been in the healthcare field for 9 years and within quality for the past 5 years.
Thanks. I'm the System Health Information Management Director and Privacy Officer for Lafayette General Health. I've been in this role for 5 years, and I've been in healthcare for over 20 years.
Right. Lafayette General Medical Center is a part of Lafayette General Health, which consists of 7 inpatient facilities and 43 ambulatory sites. Lafayette General Health sees approximately 29,000 admissions and 180,000 ED visits annually. Our medical staff is comprised of 68 employed physicians and 1,700 non-employed medical staff members. This is our information systems automation journey over the past several years. And you can see, beginning in 2013, the health system began growing exponentially with the addition of 5 facilities over the course of 3 years. Lafayette General Medical Center received a hack penalty from CMS in excess of $500,000. Following down, the measure PSI-15, accidental puncture or laceration, was identified as one of our greatest opportunities. Prior to receiving this hack penalty, we were aware that we had an opportunity with this measure, and we had begun the process of reaching out to HIM, to the coders, as well as to our surgeons to offer education. However, after receiving our hospital-specific report from CMS, we knew that this project needed to move up on our priority list. The previous workflow related to this measure was retrospective. We received data on PSI-15 approximately 2 months after it occurred in the quality department, and once we did receive that information, we would follow up with HIM and coding to discuss cases. We had found and identified variation in physician documentation. For example, surgeons were unaware of the impact of specific words that they used on coding. An example that we saw frequently was if a patient had extensive adhesions that were unexpected prior to the surgery, and those adhesions required dissection, the documentation needed to clearly state that the dissection of the adhesions was necessary or required in order to ensure that an accidental puncture or laceration code was not used. In addition, we found that accidental puncture or laceration codes were sometimes not applied accurately. And part of our process prior to process was that we would report our PSI-15 rates to the quality committee, to our quality committee, but we were lacking a feedback loop to the medical staff, which was a key component to initiating this improvement for this measure. Southeast Louisiana influenced our high PSI-15 rate, in addition to the opportunities previously mentioned. Multiple comorbidities and patients with multiple abdominal surgeries that result in extensive adhesions, as referenced in the previous example, are included in those risk factors. In addition, our area has also experienced a high unemployment rate, leading to the loss of health insurance and causing patients to delay seeking treatment until disease processes are quite advanced. Our baseline PSI-15 rate in calendar year 2015, our average rate for that time frame was 1.85 accidental puncture or laceration cases per 1,000 discharges. Taking hospital-specific reports for the HAC program years of 2016, which reflects cases from July 2012 through June 2014, and program year 2017, which reflects July 2013 to June 2015 cases. You can see that as the national risk-adjusted rate for PSI-15 declined, our rate at Lafayette General actually increased. So this indicated to us that we had some significant work to do regarding this measure. The team was formed with the objectives of developing a concurrent process for review of cases with the PSI-15 code, improving coding accuracy, and providing feedback and education to our physicians, and ultimately improving our PSI-15 rate to the top decile. A new governance plan was developed to ensure that PSI-15 data was reported to all levels of leadership. And most importantly, a strategy was developed to have a multidisciplinary chart review of all patients with the PSI-15 code, including a physician review, a review by the quality department, HIM review, IS, and as well as feedback to the surgery department. The timeline began in the summer of 2015 when the quality department began reevaluating our retrospective process and began collaborating with HIM and our surgical staff, medical staff. The HAC report and penalty was published in 2015. Locally, this was a front-page story in our newspapers and resulted in many questions from our Board of Trustees, staff, and most importantly, our community and patients. Quite frankly, many of us were a little embarrassed that our facility ranked in the bottom quartile of the nation in these measures. Although internally, we knew this was not quite an accurate representation of the care we delivered at Lafayette General Medical Center, instead of making excuses, we strengthened our resolve to improve our accuracy in documentation and coding, as well as care to achieve these things quickly. The process was implemented in January of 2016. Two lessons learned throughout this project was the importance of collaboration and communication. Prior to the end of 2015, surgeons were unaware of the impact of their particular words and operative reports, as I mentioned earlier, and coders were not aware of the impact that an inaccurately placed PSI-15 code would have on our facility. Coders and surgeons was also vital. Surgeons needed to have an understanding of how coders captured information from the patient's chart and the guidelines that they're required to follow. The quality department and the surgeons was also extremely important to ensure awareness of our current rates as well as our opportunities, as well as the surgeons regarding how they could assist in this improvement process. Surgery department meeting where we provide them with our current rate and what the current standing of our project is. Lastly, the importance of a concurrent review process was an important lesson learned. The previous workflow that I described earlier resulted in review of data approximately 6 to 8 weeks after discharge and therefore wasn't actionable. How health IT was utilized. In order to review process, we had to develop a method to identify patients with a PSI-15 code in real time, and this was achieved using health IT. Our surgeon of a procedure and a patient's electronic health record in the operative report, and then coders used the surgeon's documentation from the operative report to populate the coding summary with applicable procedure and diagnosis codes. Our IT business intel analyst created a report in the Cerner electronic health record using the AHRQ PSI-15 specifications that allowed quality and HIM to generate a real-time report listing all patients that had a diagnosis code included in the PSI-15 numerator. This was integral to our action plan. Teams collaborated to ensure that any patient with a PSI-15 code was reviewed by a clinical documentation specialist as well as our chief medical officer. From the electronic query could be sent to the surgeon if necessary for clarification. Overall, the process to review PSI-15 patient charts and educate surgeons and HIM coders increased the accuracy of the use of the accidental puncture or laceration code. The initiative increased our confidence that the PSI-15 rate reflected actual accidental puncture or laceration events and led to a significant reduction in the facility's overall accidental puncture or laceration rate from the baseline period. Health time report, that was the key component that allowed us to transition to a concurrent review process.
This slide is the quality concurrent PSI-15 process. This is a detailed workflow process on how the coders and CDI specialists use a review process to look at the PSI indicator. This is a multi-step audit process. All accounts that are put on hold until the audit process are complete. All actions noted with a star are utilizing health IT.
Of the Cerner Explorer Menu PSI-15 report, a surgeon documents the course of a procedure in the patient's electronic health record as stated prior. The coders use the surgeon's documentation from the operative report to populate the coding summary. And this report actually retrieves patient names with qualifying codes for PSI-15. The report includes the patient's medical record, number, name, as well as the qualifying PSI-15 code, which is pulled from the coding summary.
This is an encoder with the PSI indicator. As you can notice at the bottom of the 3M window, it is showing the accidental puncture and laceration code. This is a CDI tool from Streamline Health. This allows the CDI specialist to identify coding opportunities within Streamline and submit queries to the provider when necessary. These are two working opportunities pending the results from the queries that were presented to the physician. This is the HIMSS review. For the calendar year 2016, the number of PSI-15 cases reviewed were 21. The number of cases reviewed by CDI were 21. Number of cases overturned by coding opportunities were 3. 15 hack cases were 18. Number of cases sent for query were 4. Number review by the CMO and overturned were 0. And total hack PSI-15 cases were 18. The coding overturn percentage was 14%.
The PSI-15 accidental puncture laceration in calendar year 2015 was 1.85 cases per 1,000 discharges, and the rate in our measurement period decreased by about 34% to 1.21 cases per 1,000 discharges. Good physician and employee satisfaction, as well by ensuring that the quality of care delivered in our facility is accurately coded and reported. Also, giving physicians ownership in the review process increased their satisfaction. Year 2016, which was our measurement period, was calendar year 2016. We did see a decrease in our overall rate. However, there were a few months, June and July of 2016, where we did see spikes above our baseline. So we still have opportunity to improve on this measure. However, through this project, we now have confidence that this data is accurate, and therefore we're able to focus on additional improvements in care instead of focusing on ensuring that this data is accurate. The rate contributed to an avoidance of a hack penalty of approximately $700,000 in program year 2019, as estimated by this pay-for-performance dashboard that you see on the slide. We use this information throughout performance periods to estimate the impact of a potential penalty. Step for Lafayette General is, we still have some opportunity for improvement in PSI-15. Patient safety indicators into our physician peer review process to ensure top quality care delivery, as well as creating physician scorecards. Physician review for each specialty involved in a case that has a patient safety indicator code as well. And this will facilitate the communication back to physicians to close that loop. So we're involving them in the improvement process. Thank you for the story of our quality and HIM collaboration to improve PSI-15 accidental puncture and laceration in our facility. We hope you enjoyed the presentation and it proved to be educational. Thank you.
Well, Rachel and Jesse, for that great presentation. It's a pleasure to have you guys on to share your use case with our community. Remind folks where to go find other use cases on Davies on the Davies Award. More use cases, webinars, and information on how to apply for Davies Award can be found posted at the HIMSS Davies Award website at hims.org/Davies. And thanks again. Thanks for the wonderful presentation.